Ringworm infections. Though they are not life-threatening, but they have become very important because of their development of drug resistance towards commonly used drugs like terbinafine. In 2019 in India, a new species has been reported, Trichophyton indotineae. It is said it has emerged because of misuse of over-the-counter available fixed dose combination of a very strong steroid, CLOBETASOL. And this infection has spread across the globe. It has been reported from Europe and Germany, in Middle East, and from the USA. Here, I'm Dr. Anuradha Sharma. I'm bringing an insight into this important topic in my following slides. So, ringworm infection is basically a fungal infection which is transmitted man to man or from animals to man or maybe from soil. There is usually an initial ring-shaped lesion on the skin which remains warm and moist, and this lesion is scaly, itchy, and spreading radially. The central portion clears with hair loss. It is also known as tinea, and depending on the anatomic location, it is called tinea capitis when it is present on the scalp, usually seen in children, and it is seen in epidemic form because it spreads to other children very easily and usually seen in colder climates. But now it has become rare. Then tinea barbae seen on the beard and mustache part. Then tinea corporis. Here it is found usually on the moist areas of tight fitting clothes like collars. Then this is tinea pedis with a common name of athlete foot. Then this is tinea angum and this is tinea cruris. So it's a fungal infection. The three most important species have been Trichophyton, Microsporum, and Epidermophyton, and major chunk of infection went to one single species, Trichophyton rubrum. But recently, a new species, Trichophyton indotineae, has superseded and replaced this Trichophyton rubrum, and it has led to recalcitrant dermatophytosis. So this is an important emerging pathogen, and Verma and Oral, they have reported this in an article which I'm sharing here with very interesting facts. So this new species is basically a clonal offshoot of Trichophyton mentegrophyte species complex, and though it was shown to be zoophilic, but it has adapted to human beings. They have shown one case where this fellow, he used more than 100 tubes available over the counter by the chemist, used over 1 year period. And instead of improving, the whole body has got involved with the infection. And this emergence of Trichophyton indotineae goes to misuse or abuse of topical glucocorticoids, especially clobetasol propionate, which is a very strong topical steroid of class 4. So what are these fixed dose combinations of fixed drug combinations? When, without a prescription, patient purchases over-the-counter medicines on the suggestion of chemists, and they provide them with a cocktail of different drugs which contains maybe a steroid with antibacterial and an antifungal. So this cocktail of medicines is known as fixed dose or fixed drug combination. and it is quite cheaper in comparison to a simple antifungal agent. So even these chemists don't know what harm these steroids can produce in the host. The prolonged use of these strong steroids leads to absorption from the skin and manifestation of iatrogenic Cushing syndrome, which manifests as moon facies and these white stria on abdomen or thighs. There is another manifestation, this is tinea incognita. Because of use of steroids, the host's normal immune system doesn't respond. The neutrophils are not able to destroy the fungal agent, and there is altered symptom. So there may be pustules present, or maybe temporarily the lesion heals. So the true nature, which is diagnostic clinically of the ringworm infection, is missing in these cases. There's another case where these plaque-like lesions, they resemble either psoriasis or eczema, and therefore it is difficult to differentiate in these heavily treated with steroid whether it's the psoriasis, eczema, drug eruption, or contact dermatitis. And here it becomes important to get laboratory support. There's another manifestation of ringworm, onychomycosis. This is also caused by other genera of fungi, and it is chronic, it is difficult to treat, and it recurs. Usually it is more common on the toenails, and 50% of the cases are reported in elderly more than 70 years old age. It is important to diagnose it accurately with the laboratory support before starting the antifungal therapy, because it needs systemic therapy which is prolonged over 6 to 9 months. So laboratory diagnosis becomes important where there is a non-healing extensive skin lesion, or there is hair loss, also known as alopecia, and onychomycosis. So alopecia is also manifested in other autoimmune disorders where steroids are used. So it's always required to rule out ringworm infection before starting the steroids. So proper sample collection is very crucial for right diagnosis with the help of laboratory support. So samples should be collected for skin after a proper cleaning with alcohol wipes. The aseptically sample is collected by skin debridement. Whereas for the hair, either Wood's lamp is used to examine the hair follicles, or hair are plucked so that follicle is submitted for the laboratory investigation, or when it is nails, they are clipped aseptically to detect the fungal isolate. Microscopy is the most simple and fruitful investigation, because a simple KOH mount can give you information whether it is a dermatophyte infection or not, and it is more sensitive than culture. So presence of hyaline septate hyphae or chains of arthrochonidia will tell you whether dermatophyte infection is there or not. Any E cells or presence of spores should be ignored. Fungal culture and antifungal susceptibility is ideal, but it's not so easily available. Many labs are now providing molecular diagnosis, and that would be best. There's another study done by BHU by Singh et al. And it's been published in 2020 that they compared 4 oral antifungal agents commonly used, and their findings were alarming. The four drugs were griseofulvin, terbinafine, fluconazole, and itraconazole. They all showed a cure rate of around 8% at 4 weeks of treatment. Whereas at 8 weeks, the first two drugs, griseofulvin and terbinafine, didn't improve even one-third of patients. Whereas itraconazole was able to show a respectable number of 66% cure rate. The usual treatment is for localized skin infection, topical azole therapy. There are several azoles available in the market like clotrimazole, miconazole, luliconazole, itaconazole. So these can be used locally twice a day for a, few weeks, usually 2 weeks, and ideally the antifungal ointment should be applied in the surrounding healthy skin of a 1 inch margin along with the lesion regularly, because this fungus grows in the keratin layer of the healthy skin. So this margin should be covered well with the antifungal agent, and once the lesion has healed, the antifungal application should continue for further 2 weeks till the keratin layer is sloughed off, which contains the fungal agent. Luliconazole has been shown to have superior activity for Trichophyton indotineae. Systemic treatment is required for three conditions. One, for extensive skin involvement. Two, for any nail infection. And three, for hair follicle infection. So we have seen that among all the four agents, only itraconazole is showing a decent response rate. So this can be used as 100 milligram drug twice a day for 8 to 12 weeks, depending on the response. But it has several reasons to be cautious while using itraconazole. One, it shows erratic absorption when taken orally, and it should not be given along with antacids. It requires acidic environment for proper absorption. So it should be given either with orange juice or colas. Second, it among all azoles, it has the longest list of drug-drug interactions. So we must elicit a proper drug history from the patient uh, because it can create a lot of toxicities because of this interaction. Then this drug also has several adverse effects, and even patient can land up with heart failure if not supervised properly. This drug itraconazole is widely used for endemic mycosis like blastomycosis, histoplasmosis, and other endemic dimorphic fungi. And we should look for good quality of this product in the market because azole drugs capture a large part of pharmaceutical industry, and spurious uh, samples are also available. Another report from US shows that a patient has not been cured over 20 years period of treatment. So, treatment-resistant dermatophytosis is a reality, and this is an emerging public health threat. So, what can be done to stop this downfall of management of dermatophytosis? One, don't rely only on clinical diagnosis. Take the support of laboratory results, and simple KOH mount will provide you a very useful information which is easily and cheaply available in most of the areas of the world. If possible, get done ID and AST of the fungus, and please don't use any over-the-counter combination preparations for local application. Remember, quality of life is severely hampered in chronic patients, though it is not life-threatening. Therefore, CDC has released some information for patients like certain do's and don'ts. So patients should keep themselves clean and dry. After coming in contact with the pet animals, they should wash their hands, and if animal is infected, they also need simultaneous treatment. People should change their innerwear regularly, including socks, on daily basis. Common bathing areas like in military or in gymnasium or sports complexes, there are more chances of transmission of this infection. So people should not go barefoot for bathing. And no personal use item should be shared with others. Another very important thing is that there is mushrooming of gymnasiums, beauty parlors, spa centers, massage centers, swimming pools without following adequate hygienic conditions. So they become an important epicenter of spread of these infections. So another poster shows why it's important to know about these superficial fungal infections and what to do. So, what it is and who are affected. So, apart from healthy patients, even diabetics and immunocompromised patients, they suffer more severe manifestation. Then there is increasing resistance to the commonly used antifungal agents, and there's a constant rise in this resistance, and it is also spreading across the globe. Then they suggest if there is no improvement with the local application of the antifungal agents, one must consult a physician, and they should take support of laboratory to institute proper antifungal treatment. So Trichophyton indotineae has spread across the globe, and it is resistant to terbinafine because of point mutation. And misuse of these CLOBETASOL with antifungal and antibacterial has led to its emergence. So it is a request not to use these combination agents and resort to a proper prescription for these manifestations of ringworm or tinea infections. Please help me in spreading this information for other people. Thank you.